to talk about, I think, to start to work with soft tissue correction on the aesthetic zone. And I choose color compromise areas. And to be very sincere, I think it's the easiest way for us to understand and to practice soft tissue on the aesthetic zone. Because of the requirements that we need to face for this kind of surgery are lower. And you're going to talk about not just the color compromise area on natural tooth, but also on implant sites. So you can understand the difference, how to handle between one and another one. And after that, we can maybe step up for a next stage, cases that we need to correct, not just the color change because of the thin phenotype that we are working with, but also volume, also to bring the tissue of the cervical margin more coronally, and in the last stage to really augment huge sites, maybe augment the tissue and the interproximal sites to augment tissue or papilla in area that is going to receive implants and so on. So it's a sequence of understanding how to treat the tissue and how to nourish the connective tissue that is going to be used to fix this kind of situations. Okay, thank you guys on Instagram to be here. I just need to turn down the comments because otherwise a great part of the screen is going to be fulfilled by the comments here. So I'm going to turn it off, and in the end, if you have some time, you can really make some questions. If you have some questions, you can just send it straight to me on Facebook, on Instagram, so you can do that, and I'm going to answer these questions tomorrow. Okay, so let's make this time worth. We have a less than one hour to talk this subject. So I have some case and some very old case, some very new one, different kind of quality of documentations, but I think the whole set is going to bring everything I want to talk to you this morning. This morning here in Brazil is 9 a.m. and a case like this one. Okay, if you see these two central incisors here, these patients have been changing the crowns twice before came to our office and never was satisfied about the result of these crowns. And what is the problem here? The crown is very nice, okay? The ceramic, the anatomy and so on is very fair. The problem is exactly the encounter of the crown with the soft tissue. I have in one of the crown maybe a small line here showing the dark root, but the problem is this patient had a very high smile line, and you see the difference in the gingiva, on the color of the gingiva. So in a thin phenotype, you're going to have any difference in the color on the background showing on the surface. Does not matter that it is a dark root endodontic treat many years ago, if it's titanium abutment, if it's the implant threads that is close to the surface and showing on the surface of the gingiva. So I have how to block this difference in the color. Does not matter what you want to block. If you augment and if you change this phenotype, you have the chance to hide any difference in the color. How much of the soft tissue is needed for me to have this effect done? 2 millimeters, okay? 2 millimeters of soft tissue, and does not matter what you have behind that on the background. You're going to simply hide this difference in the color. If you have a titanium, if you have zirconia, if you have root, does not matter. You're going to hide what is there. This is a very nice work, a very nice paper that was done, and they change different abutments and colors of the abutments in different thickness of phenotypes to test if the color influence the viewer and the thickness of this area, and the thickness up to 2 millimeters was able to hidden everything behind that. So what we need to do, a huge augmentation to hide that, or a small augmentation? So a small augmentation, it's enough for us to hide any different color. In a natural case, in a case like this one, the phenotype is close to 0.7, 1 millimeter in thin phenotype. So 0.7, 0.8, it means that you need to bring a connective tissue that do not need to be larger or thick than 1.5 millimeters, and that is really a thin connective tissue. It's easy for us to handle, it's easy for us to harvest, it's easy for us to bring on the tunneling area, so I do not need to bring a huge connective tissue. I just posted, I think 2 days ago, about exactly the thickness of our connective tissue when I'm intending to root covering. And I see many people harvest very, very thick connective tissues to treat root exposition, and that do not bring any benefit in the result. Thicker connective tissue. We know through the researches, we know through the experience that connective tissue for root cover up to 1.5 millimeter do not add any better outcome in terms of 100% of coverage. The same thing here. I do not need to bring a connective tissue that is thicker than 1.5 millimeter after the digitalization, okay, to hide these different in color. Of course, I have some cases, especially related to implant site, that are going to not just block the difference in the color of the background, but also are going to augment a little bit the volume to have a better emergence profile, okay? Is not the case for natural root situation like this one here. Let me just clarify one point here. We choose the subject to treat the color compromise area. We're not talking today about root coloring. We not talk today about augmented the volume to have better emergence profile, because that is going to require different approach on the site preparation, and we're going to do and talk that tomorrow, okay? Is the next stage that we need to face. And okay, how can we approach a case like this one that I have this different? We need to bring some connective tissue in, and we're going to talk also about the difference in the choice of the connective tissue between harvest that from the surface as a free gingival graft and promoted the digitalization, and also to harvest from the deep part of the palate, not close to the surface, the subepithelial connective tissue graft harvest from the palate, which is the difference from one and another. We're going to talk that tomorrow, because that, I think, brings a lot of maybe different on the outcome that you have to talk, okay? So what we need to do in case like this one is just really augment this area. We're not going to cover a case like this one today, that I need not just to change the thickness, but also have to bring this tissue down, fulfill the papilla area. So this is another level, another approach. We do not have the time to really bring this kind of situation. And you're not going to talk situation like this one, that's all the same. I need to bring huge grafts here, treat completely different, not just the recipient area, but the graft is going to require different thickness and so on. So we're going to stay simple today to treat exactly this kind of situation here. Okay, so I'm going to already go to the drawing table because I want that you're going to check one thing with me. Okay, so I'm going to do a design here and of the natural crown, and I'm going to do a design of the implant situation, and you're going to understand the difference on the approach that I had between one and another one. Okay, so first we're going to talk about natural roots. What I have here, a color compromise root, thin bone. Sometimes I have the adhesance of this bone. That's why the root shows on the surface. So it's very thin area here. And of course, I have a thin phenotype. Of course, why? Of course I have a thick phenotype, because if I had a thick phenotype, I had no problem showing the difference in the color for this kind of situation, okay? So when you are working in a natural root like this one here in a thin phenotype, that is going to decide exactly the way you're going to approach the area here. If it's going to be split thickness or full thickness flap. Let me ask you something. If you have a very thin phenotype here, you're going to have how to do a split thickness flap in this area, augmented a lot the risk to have a necrosis of this flap here. No, you're going to stay safe, okay? The requirements of this area are very low in terms of healing, and I'm going to talk that through in a moment. So in this kind of situation, when you treat natural roots here, you're going to full thickness flap, okay? And let me explain something for you here that is nice for us to understand. What you have here on this area, the keratinized area, because remember, I have keratinization until the mucogingival line, and up to the mucogingival line, you have the mucosa and the muscles here, right? What I have here on this area is more or less something like this. I have the epithelium from the sulcus, the epithelium junction here, very few cells, not starting from 1, 2 to 10, 15 cells. And after I came outside the sulcus, I start to have a huge layer of epithelium here. And of course, on the top of this layer of epithelium, I have keratinization on this area. Okay, good. And here I have the starting of the periosteum. The vascularization of this area here runs inside the tissue. So the blood vessels run inside the connective tissue. And as you have here a thin phenotype, it means that you have an area on the surface that is the epithelium. Just below that you have the connective tissue, and in the middle of the connective tissue you have the blood flows running inside this area. It means that you try to do a split thickness on this area, probably you're going to cut something in the middle. Even if you cut close to the bone surface here, even though you're going to cut and damage some of the blood vessels of this thin phenotype here. So I prefer to have a full thickness and preserve all the blood flow of this sensitive area of my flap to have a result that is not going to have necrosis of this area. Okay? And remember one thing, for this kind of defect, how is the thickness of the connective tissue that you are going to bring in place? Remember, we already told that I do not need to bring more than 1.5, 2 millimeters of connective tissue. As this connective tissue is not thick, it's thin, even having just one surface here to nourish the connective tissue, I'm going to explain that in some seconds, this connective tissue is going to be very well nourished, okay? Why you told me, Ricardo, that there is just one surface here? Because I have different recipient area for my connective tissue. I can prepare that in completely different ways, okay? I can have the recipient area for my connective tissue. I can have bone on the background, and bone is not a good surface to nourish my connective tissue. For the ones that already had or try a free gingival graft without in an area that without periocean here, you know that the failure is very high in this kind of situation. You can have the root of your tooth here, also no nourishment from the ground, but you can prepare this area with and letting the periocean on the ground. And okay, the periocean is the best nourishment recipient area that you can have, but that means partial thickness, not full thickness, okay? And the difference between one situation and another sometimes is the thickness of the connective tissue graft that I'm going to bring in place. Because thin connective tissue, you can have just one of the sides, one of the surface of this connective tissue being nourished, and through just one of the surface, you can nourish all through the body of this graft. It's completely different when you bring very thick connective tissue in place, because some situations are going to require that I bring very thick connective tissue. Do you remember the previous slides on implant sites and so on? So in that kind of situation, I need really to prepare the recipient area to have the background, the bed, the recipient bed well prepared with nourishment surface, it means periocean, and also the flap bringing nourishment both sides of my connective tissue. That's right, if you understand this kind of requirement for this situation, you see that one thing combined with the another one. I have thin phenotype here. I need to bring a thin connective tissue in this area. To be safe, I can have full thickness flap, letting the bone here or even the root exposed. That is not going to be a huge problem in terms of nourishment and survival of my connective tissue. And I'm going to let all the flap preserve with periocean, connective tissue, and epithelium on the surface to have during the healing diminish the probability to have necrosis of the flap. Okay, so in a while I'm going to talk about implant, that in this already stood under this drawing. I need to design a new implant here for you to understand. But let's return, let's talk first about the situation of the natural root. Look at this root, look the color of this root. It's completely dark, okay? So really the color here, the change in the color is huge. Probably this different in the color is due to the metals using to on this core. We have some combination of the alloys on these cores that cause really changing in the color of this root. I think this woman at that time, it was 7-8 years ago, had less than 30 years old, so pretty young woman. What we're going to do, full thickness flap, we're going just detach the flap from the ground, okay? And you need to use a flap elevator. As we're going to do that through the sulcus, and I'm going to tell you the others approach later, we're going to do that through the sulcus. We're going to do that with a very small and delicate flap elevator, a tunneling instrument. In that time, I have a very rough and rude tunneling instrument. You see, it's not a good one. The refinement of this instrument is not a good one, but if you are very careful, you can do this job, okay? I think many people give a lot of value in the instrument and less value in the care, in the handling. And really, I think it's different. If you pay attention, if you are careful and you know what you are doing, even using not the best instrument, the best sutures and so on, you can perform in very fair results, okay? So what we need to do, I need to detach the tissue that is going to be open to have the space to bring my connective tissue in, okay? How large is the area I need to prepare? And that is a very nice question. I'm going to answer that in a few moments, but I'm going to start to answer now. Remember one thing, we need to augment the volume. In which area? Just when I have or where I have the color compromise situation. It means that I do not need to bring the connective tissue on the lateral crowns, okay, right? So just on the two central incisors. Another question, I need to bring the flap to cover some recession? No, I do not need to bring the flap. So you see, or you are notice that I do not need to releasing a lot the area in distally and even apically to have room for my connective tissue graft, because my connective tissue just is going to be laid down on the area that have color compromise different. And I do not release a lot of the tissue to bring any tissue coronally, because the tissue is already in the right position. So this requires a very simple preparation of this area. And usually this preparation is full thickness flap all over, okay? So everything you need to do is detach the tissue from the ground, from the bone, full thickness flap with a tunneling instrument. As you're not going to advance a lot of this tissue currently, you do not need to bring this tunneling way far away from the lateral incisors and not apically, a little larger than the size of your connective tissue graft, okay? And here on the final slide, I have my connective tissue. On that time, we have a lot of preference to use the subepithelium connective tissue graft. That was 7-8 years ago. Nowadays, we have, in many cases, how to choose between one technique and another. I'm going to tell that tomorrow, the difference between one and another is a huge conversation, okay? Okay, just one moment for me, I need to jump to the slide. So we just have the tunneling, and now we're going to bring the connective tissue inside this place, okay? And I'm going to bring the connective tissue with the sutures in place. So I have here on the first part of this slide my anchorage point, okay? The area that I'm going really to bring the connective tissue. Usually I like to have the anchorage point done in an area that was not tunneled. Why is that? Because I still have on that area the periosteum attached to the ground. It means the tissue, the flap is stable. And if you want to have an anchoraging of something, it's better to have a rich and stable anchorage point on this area. If you have tunneling all around this area and you have the anchorage on this flap that was released is movable, You are trying to fix something in something that moves, so it's not a rigid and stable anchorage point. And we have the tunneling area not larger than under the papilla on this area. So exactly we can check with a probe how long the tunneling went, and 1 millimeter away from that we can engage with the suture. We're going to see some slides about that, I think in the end of the presentation or tomorrow morning, how to do these tricks to exactly know the proper area of engage the suture. So we came from the periosteum with the probe, we open room for the needle to run between the flap and the bone and emerge on the sulcus. Once you have one sulcus, you're going to run from one sulcus to the another one with the back part of your needle in front, the non-cutting part of the needle, okay? So you move the needle backwards. Why is that? To not engage and to pinch anything on the middle, not to engage periosteum connective tissue, because if you engage something in the way from one tooth to the another one, what happens when you try to bring the connective tissue? Of course, the connective tissue is going just stuck in the middle of the way. And we have engaged also the connective tissue, and now it's time for us to bring the connective tissue in place, okay? So we have one side aligned, another side aligned, and you have a middle sutures between the two crowns. We're going to talk about that later, how to design these sutures and how to do the central sutures. That is very important. And we align this connective tissue border to border. Actually, I have some excess of connective tissue on the cervical margin, and here is the, I think 2 months after the healing. You see the difference in not just the volume, you see the difference in the color matching. So we completely block any difference in the colors. And remember one thing, this is the same crowns. We do not have changing the crowns yet. So actually the patient, okay, now I need to have new crowns in place, so you can fix many problems with the soft tissue approach in case like this one, okay? That is nice. Let's talk about implants, and this is very, very important for us to discuss the approach of full thickness flap or split flap between the implant and natural roots, okay? Let's take a look on this CBCT scan, and this CBCT scan is exactly from the same patient. I have an implant in one area and I have a crown, canine or something in the another one. I want that you take a look on the total thickness of the soft tissue on the buccal surface of this crown. Looking on the tooth 13, and you're going to check how is the thickness. Man, is way thinner. It's thin. It's exactly what I have designed here on the drawing board. If you try to split thickness this area, you're going to have problem. Hold this information. You can do full thickness until the mucogingival line, and up to the mucogingival line, you are free to do split thickness in areas that you want to release the tissue. We're going to develop that in later, okay? So at least where the tissue is thin, you're going to full thickness. And you see the difference on my implant area. Usually on implant area, you're going to have a little more of tissue available for you to decide to do a split thickness flap, okay? And I'm going to once more return to the drawing board to explain that. One second, I just changed the presentation, and good. So let's return in, do the implant situation here. So this is the implant. I have all the threads here, You can decide if you can have here external connection, if I have a Morse connection. Let's design a Morse connection because Morse connection is tough for me to work on with the flap, okay? This is a Morse connection. What I have here is even design a very thin tissue. I like to adopt partial thickness on case like this one, okay? And here is the crown. Right. Why partial thickness? Because if you have compromise of colors, it means that you have some of the threads of your implant showing through the bone. Maybe you have the abutment here. And remember one thing, if you have the threads exposed in this area and you're going to open full thickness flap, you have some problems here. First problem is the nourishment of the residual bone that stay on the threads. You're going really just move apart all the nourishment of this bone. Maybe you're going to lose the residual bone that stay on the threads, but that's not a big deal, okay? What is the main points here? First of all, sometimes you have no bone, but you still have a good connective tissue attached to the titanium surface or the bone surface here. It means the biologic width protection of this area. And when you detach full thickness flap, you give again another chance for this area to really to be infected on this area. So you're going to have a higher chance to have a pocket on this area here. And if you have the threads here, it's not so easy for you to do full thickness flap with the tunneling instrument. The tunneling keep just bumping over the threads, and actually what you're going to do, you start to be rude with the tissue that is still attached between the threads. You're just going to tear part of the connective tissue from one place to the another one. And so if you're going to compromise the blood supply of the residual bone, you augment the chance to detach everything, to have the biological width migrating apically, and you're going to be rude with your connective tissue or periosteum here, trying to move full thickness on this irregular surface. And actually, even on case like a Morse connection, it's very difficult for you to do this curvature here, detaching full thickness flap. What I prefer to do is a partial thickness, but really with my blade running very close to the threads. Actually, the blade just scrape over the threads here. It's almost the same approach that you're going to do with the tunneling instrument, but you're going to use a micro blade or a blade to scrape over the threads. So you're going to let on the surface of the implant preserve some of the periosteum, some of the connective tissue, still nourishing, still protecting this area. And you're going to try to let as much as possible of the volume of the tissue on the flap, this area here, because it's thin, and you're going to try to protect that, okay? So usually on implant surface we have exactly this kind of approach. Let me just move here. And there is one more thing that we need to understand on case like this one. Let me check the time. Okay, we have the time. Case like this one that you have color compromise, one implant situation, what you have here? You have two natural crowns on the surroundings, and you have an implant that was done many years ago. Probably this implant, immediate implant placement, immediate loading. I have no problem here with the papilla position. Let me just change in here to check the other slides. So the papillas are perfect. The cervical margin, I have not much retraction because I'm going to really plan here a crown lengthening on the another crowns, but I have a different in the color. Can you see that? So a difference in the color that I need to augment the soft tissue, and a difference in the volume of this area. Just 1 second here. So I need to treat this area. I would like that you try to understand something here when I told you that is the easiest way for us to treat this kind of situation. Okay, so let's just changing the drawing board once more. Every time that you are planning your surgery, you need to read the recipient area. You need to read the defect. What I mean to when I say that. Look at this and try to follow what I'm trying to say here. What is the situation? I have a central incisor here. I have my implant in this area, and I have the lateral incisor here. So, okay, external connection, good. This is not a good design of an implant. I think that's why the implant companies do not hire me to be advisor. I think is that. Look at that. What you have on this crown here, you have the volume all preserved because you have the bone preserved here because of the presence of the natural crown and root, so the soft tissue is preserved. Okay, and here all the same. What you have on this area here that had immediate implant some years ago, problem without filling the gap with the biomaterial and without any connective tissue graft to augment the thickness of the buccal area. You have some collapse of the tissue. And this is the easiest way for me to prepare the recipient area for a connective tissue graft. Okay, if you want to fix color change and volume here, what you are to try to do is bring the tissue here. Okay, let's design the final contour. That is the idea, right? So you're going to bring in this area a connective tissue like this one here. Let me tell you a story here. No, I'm not going to do that because it's going to take so long. What I'm going to do here is one thing. Look how much of tissue you have projecting to the inside of this defect. You have 1, 2, 3, 4, 5, 6, 7, 8 millimeters, right? If you detach this tissue from the ground with an incision that you can do through the sulcus of the crown that was once here that you remove, and you're going to do this incision here close to the bone. Sometimes you scrape on the bone, sometimes you scrape on the threads of the flap here, or the implant, and so on. Once you have this part free from the ground, look at that. It's going to be the total length or the total tissue that you need to move it to the outside of the arch and to open this place for this connective tissue graft to be tucked inside this area. The question is, you're going to need extra tissue to be released to cover this connective tissue? No, you do not need, because you already had the total length of the volume here of the tissue to be enough to have protect and open the space for your connective tissue to be moving in this kind of defect. It's much more difficult for us to have this connective tissue here grafted in a place like this one, because if I want to augment this area here, you see that I'm going to need extra tissue, extra volume of the tissue to really have the space for this connective tissue to be brought in place. It means that you need to release extra area. It means that you need to release from the lateral areas. It means that you need to release to the apical area, okay? That is why I told you in the beginning that just treat color compromise area is the easiest approach because the requirement in the preparation of the recipient area are simple. When you need to bring the tissue corally, when you need to bring the tissue over the top of the crest, you're going to have more problems, so we're going to discuss that tomorrow, okay? So let's move once more. And so here how I can treat and I'm going to prepare this area, really doing an incision close to the, oh my God, let me just, I'm going to bring this incision close to the, that is right, close to the bone surface, close to the threads, scraping the blades on this surface, and when it's possible, you're going to remove this crown from the place to have free access the intrasulcular area of the old crown, okay? Otherwise, you're not going to have a proper access to do a good job on this area. And how long it take for us to do this site preparation? Let's hope that the video start to run. Okay. Pay attention because it's done, okay? Not longer than, I don't know, 15 seconds. You just bring your blade close, scrape over the bone, bring it out. You do not need to do anything else. Your preparation site is ready. Simple as that, okay? So you're going to release the crown. This is the pictures of the blade. You're going to see more cases, okay? And my connective tissue have the proper space to be brought inside. Why this vertical orientation of my connective tissue is not a horizontal orientation? The question is, I need to graft on the central incisors and the lateral incisor or just on the implant side? Just on the implant side. I do not, if you remember the occlusal view of the defect, I do not have defect under the papillas, under the shoulders of the papilla. The bone is still there, okay? I just need to fix the center. Why am I going to augment a lot the tissue? I do not need to do that. I do not release the tissue on the lateral and the central because I do not need extra releasing to bring the flap over everything. Do you remember? As we read the defect from the occlusal view, all the tissue I need is there, okay? So here we are just trying the graft in place, and that is something that I always tell. Every time that you have the chance to try in the graft in place to see if you have enough room for your graft, do that before try to move the graft with the sutures in place. Because if you bring or you tuck the graft inside the area prepared, and you need to struggle to bring the graft inside, okay, to tuck the graft, and you let the graft alone, the area try to move the graft outside. It means that you do not prepare the site properly, okay? If you have the chance to try in the connective tissue in place, do that. Okay, the site is nice, well prepared. My graft is stable alone, is with passive fit on this place. Now I can take it out again and start to do that with the sutures, okay? We're going to talk about the sutures tomorrow. And here's my graft. And after some time, I can make the conditioning of this graft, changing the soft tissue contour. And after the end of the treatment, I have all the problems of this patient fixed, not just through surgical approach, crown lengthening, but also restorative work for this patient. Okay, that's good. So we have more 15 minutes, and I'm going to show really fast two cases here. This is more the same. On this lateral incisor, I have a difference in the color and of course a small reduction of the cervical area here. So we need to graft once again. Oh, this is the final result, sorry. So once more, we brought just the connective tissue exactly on the area I need to treat. And this is the time we took to prepare this area. Once more, a microblade close to the surface of the threads, scrape over the surface of the thread. You're going to move one side to the another one, doing a swing movement, and that is it. All the tissue needs to have prepared area is done this way. So we're going to bring now the graft in place with sutures that start in the apical part. We align this graft vertically, not horizontally. I do not need to bring this graft under the central incisors or the canine. And here we brought a blunt instrument, can be a probe or something like that, to open the space for your needle to run between the bone, the threads, the residual periosteum, and the flap without engage anything in the way. It's nice for you to use in this case a more straight needle, okay? 3/8, so it's a more straight needle and longer, at least 13-15 long needle for you to do this running inside this area without engage. A short needle, you're going to have a lot of problem to engage apically and come out on the sulcus area. Okay, so now we are engaging the connective tissue and we return back to the apical margin, and we're going to tunneling and bring the connective tissue inside this pocket. Okay, so this is the connective tissue, and we're going to give 2 additional sutures on the borders. When you have the proper time, we're going to talk about that, and that is done. And now the crown in place. You see that we release a lot the crown, so it's a very thin area not to pressure the connective tissue. And 7 days, and this is the coping being tested. You see the different color, volume, texture, everything to final to move this case to the final treatment. That is nice. Okay, let's just move one slide down here. Let me talk to you about something. Let's return to the drawing board, because all the case that I was showing to you was case that we have the chance to remove the crown to reach to the sulcus, this area, and that is going to be the easiest way for you to do the job. Not only in natural situation, in natural crowns, okay, natural roots, sorry, that you remove the crown, especially in implant area. Implant especially, because if you have, or if you remember this situation here, usually if you lack volume on this area and you need to tunneling or to split this area, look at the emergence profile that you have on the crown. So you have a very fat emergence profile, a long rounded emergence profile. How can you do this curvature to prepare this area? How can you come inside here with a blade, do this curvature, almost 90 degrees of curvature, to now engage over the buccal or the facial surface of this implant? It's very difficult for you to do this job. But without the crown here, it's a straight line. It's easy for you to do. So every time that you have the chance to remove this crown, do this job. Even in natural roots. So this situation here, if I'm remove the crown and have straight access to this area, is easy for me to tunneling without the emergence profile of the crown. That's right. So if you not have the chance to remove the crown over implant or over natural, what you're going to do, you can have an alternative access to this area that is through a vista incision. So vista incision is going to be a lateral incision in vertical direction. So coronal apical incision, never this way. Oh, sorry. Never this way here. Why is that? Because here you're going to compromise a lot the blood flow. When you do incision this way, you can start tunneling from the side to bring the connective tissue to your interesting area. It's more difficult to do this job this way. What you see on the case is that you have a gray area. I think this patient just received all the new crowns, completely new treatment, and he still have some difference in the color of the central and lateral incisor. So we need to fix that to connective tissue graft. As all new crowns, we're going to try to not to damage or to remove the crown, and we're going to try to just fix the restorative work result, okay? So let's check a nice video of this procedure. Okay, the video is already kicking in. So this I decide to do the vista incision through the frenum of this patient. We remove the frenum because I could have done that on the canine or between central incisors. I decide to do to the frenum. And from that point one, natural roots, full thickness or split thickness. Go full thickness, okay? It's easier, safer, safe for you to do the job, and you're going to just tunneling. That is easy, okay? And you're going to tunneling until the area that is not problematic of the color. It means close to the canine. I do not need to release this tissue. The tissue is already in good position. I just need to open the space for my connective tissue to get inside. And we decide to do that by the lateral approach, because when you try to tunneling with the presence of the crown in place, sometimes you just going to enlarge a little the alignment of the gingival margin, and we prefer to go to the lateral approach to preserve the contour of the tissue around these brand new crowns, okay? And we are collecting free gingival graft that we're going to use and make the deepitalization of this graft. As far away as you move to collect this graft, I think you have a small improvement on the quality and the collagen percentage of this area, close to the second molar. And I do not have the rugus of the canine and sometimes the premolar present here, so it's easier for me to make the deepitalization. And the recovery of the patient is easier, okay, because the patient can control all the food on the anterior zone and the opposite zone, and so it's more comfortable for the patients to have collected in the back part of the palate. There is some small points that we can bring about that, but the subject is not the harvest side. This is a collagen fleece, the collagen membrane that we use to protect this area. We have the sutures done to hold that in place, and I think in that time we still use suck down molding to protect the whole area. Nowadays we prefer to use flowable resin. We're going to talk about that tomorrow, okay? Don't worry about that. So it's cross compressive sutures that we start on the buccal side. Under the contact point, we engage the apical margin of this donor site and just return and the distal contact point. It stay in a cross arrangement to hold the fleece in place, okay? Good, we have 6 minutes to finish this case. I think it's enough time for us to finish the video. So the deepitalization, I prefer to do that by hand, outside the mouth of the patient. I get used to do this job, and I think the main deal about doing the deepitalization outside the mouth is to have a steady surface to work on with. Never do that over gauze. A lot of gauze, and what you're going to have, the surface is completely soft. You cannot have the grip to properly do the epithelialization. Some people like to use a wood tongue retractor because the grip of the wood is very nice. So do that, it's good for you to use. Or you can use a microplier and you're going to align the microplier exactly in the same direction that you are doing the digitalization process. So also is going to work pretty well, okay? And all the time, saline, saline, saline. Never get your graft dry, okay? Always a lot of saline on this area. It's very tough for you to tell visually which place you have done the digitalization. So all the time, pay attention what you are doing, look all the time what you are doing, do not stop to do another thing, to talk to someone else, do all the job of the digitalization from the beginning to the end without stopping, because you need to really see what you are doing. Look at that. We are starting the anchorage point from my sutures. You see the probe? The probe is checking exactly in which point I stop the tunneling. So from that 1 millimeter distally, it means that the periosteum is stable on the bone. It's exactly this point that I'm going to engage my needle and run through the sulcus. So it's a very stable anchorage point. From one sulcus to the another one, from another sulcus to the vista axis. You see the needle running backwards, at least with the non-cutting edge in front, okay? And now you are just getting or pinching the connective tissue graft. I'm checking exactly in which level I'm going to just engage the connective tissue graft. Remember one thing, be very careful in the first engagement when you start the suture. Many people start the sutures too apically. What is going to happen that is going to make the alignment of the graft at the end of the procedures apically placed. You're going to miss the arrangement of the connective tissue on the cervical margin. That is exactly the most precious area that you need to bring the connective tissue, so close to the cervical margin. Right. And we are just bringing in the connective tissue in place to align that very close to the cervical margin. Okay, so one lateral suture, we're going to make or do the same suture on the mesial area. Do you see this approach, the Vista approach, allowed me to not distress the cervical margin, okay? To really have a very low risk to have a bad outcome, because if I have some exposition of the root or something like that, I'm going to have a lot of problem maybe with this patient needed to change this crown again and so on, or regrafting. So that is why we decide to do a Vista approach, okay? Okay, I'm going to jump because I'm going to show these sutures for you tomorrow, okay? I promise to you that I'm going to talk about these sutures just tomorrow. I'm going to show you the result. I have some seconds to go. This is the final arrangement of the sutures. I'm going to talk about this middle suture here tomorrow and have the proper time. This 7 days of post-op, you see all the problems of the patients gone for me to solve this problem. Guys, think a lot. I'm going to need to end the live here from Instagram. It's 1 hour, so I have just some seconds remaining. I expect to see you tomorrow. Okay, and from the guys of the Facebook, don't worry, we're going to bring these 10 seconds, 2 minutes of this case tomorrow, and have a very nice case exactly with the same approach of the sutures. We're going to talk more about the sutures tomorrow. So if you have the chance to be here tomorrow, you'll be very welcome. So have a very nice day. Does not matter where you are. I wish you a very nice weekend.